So 71st question is, a 48-year-old female underwent total hysterectomy with bilateral salpingo oophorectomy. The surgical specimen revealed solid ovarian tumor and histology revealed thecoma fibroma. Which one of the following is the most appropriate statement regarding this condition? So 20% of such tumors are bilateral. Endometrial hyperplasia is often associated. It is always associated with cross ascites. It is derived from the germ cells. So first of understand what is thecoma fibroma. Thecoma fibroma of ovary. So these are sex cord tumors, sex cord stromal tumors of the ovary. Now the word fibroma means mainly fibrous tissue. So there is fibrous tissue, mainly fibrous tissue. And thecoma means it contains theca cells. And theca cells produce estrogen. Now estrogen will go to endometrium, and will cause endometrial hyperplasia. Endometrial hyperplasia, which can cause abnormal uterine bleeding and which may also cause occasionally endometrial carcinoma. Endometrial carcinoma. Now coming to options. Option number A, 20% of such tumors are bilateral. No, generally they are unilateral. So these tumors are unilateral tumors. Usually so A is wrong. Endometrial hyperplasia is often associated. Yes, this is correct. And the reason is that theca cells produces estrogen. So second is correct. It is always associated with the gross ascites. The associated word is very extreme. The always word is extreme. It is always associated. It's an extreme statement. That it will always be associated with gross ascites. No. Generally, fibroma are associated with the Meigs syndrome. And Meigs syndrome has ovarian fibroma, ascites, and pleural effusion. So always is wrong. It is derived from the germ cells. No, we talked about it. They are derived from, these are not the germ cell tumors, but rather they are sex cord stromal tumor. Sex cord stromal tumor. Example of germ cell tumors are Examples are dysgerminoma, teratoma, etc. So answer will be B. That is thecoma fibroma is often associated with endometrial hyperplasia. Now coming to second. In POPQ classification for uterovaginal polyps, the only measurement done after reducing the polyps is genital hiatus, point C, point D, total vaginal length. So what is POPQ classification system? POPQ means pelvic organ polyps quantification. So we are going to quantify the polyps. So quantification, classification is there. And what is done in this system? In this system, the hymen, the level of hymen is taken as the reference point. The points which are proximal to hymen are given negative points, and the one which are distal to hymen are given positive points. But our question is asking that which of them is done only after reducing the polyps. So the answer will be total vaginal length. Why? Because it represents true anatomical length of vagina. True anatomical length of vagina and should not be shortened by the prolapse, and should not be shortened by the prolapse. While the other measurements, all other, not just these options but all other, the most points like AA, BA, AP, BP, all other points, etc., etc., they all are measured with the prolapse. With prolapse, they all are measured with prolapse at its maximum descent, during straining, but the only measurement that is done after reducing the prolapse is total vaginal length. So D will be the correct option. Now coming to the 73rd. Which of the following are essential steps of the Fothergill operation? So Fothergill operation, so these are directly taken from the Datta's table. So what is Fothergill's or Manchester operation? So the operation is designed to correct uterine descent associated with cystocele and rectocele, where preservation of uterus is desirable. So we preserve the uterus. So Fothergill operation is done to preserve the uterus. The indications are preservation of reproductive function, and second, when the symptoms are due to vaginal prolapse associated with elongation of the supravaginal cervix. Now, what are the steps? So steps are, first we do preliminary dilatation and curettage, then we amputate the cervix. So cervix is amputated, then plication of Mackenroth's ligament in front of the cervix, and then we repair it, anterior colporrhaphy, and then we do colpoperineorrhaphy. So again doing it, first we do preliminary dilatation and curettage, then we do amputation of cervix, and then we plicate Mackenroth ligaments in front of cervix, and then we do anterior colporrhaphy, and then we do colpoperineorrhaphy. So coming to options, so the first option is laparoscopic or vaginal ligation. No, this is not done. Amputation of cervix, yes, it is done after dilatation and curettage. Plication of Mackenroth's ligament in front of cervix, yes, done after amputation of cervix. Then we have the anterior colporrhaphy, and then one option that is left is, which can be asked, that colpoperineorrhaphy can also be done. Okay, so option will be 2, 3, and 4. So D will be the correct option. Now coming to next, 74. Which of the following are indication of the cold knife conization? So first is inconsistent finding, colposcopy, cytology, and directed biopsy. So this is correct statement. For example, you find on the pap smear, it suggests that it is HSIL. On biopsy, when you do biopsy, you find it is CIN1. And when you do colposcopy, these findings do not match. Now you will be doing diagnostic conization. So you will be doing cold knife conization. So first is correct. So first option is correct. Coming to second, there is a persistent CIN1 lesion in woman willing for future fertility. So this is not done, because when you are doing CIN1, so when it is only CIN1 lesion, you are going to manage it conservatively, and that too persistent one. It is persistently CIN1 only. You are doing repeat cytology, everything, HPV testing, follow-up you have done, and it is now CIN1 only, persistent CIN1 only. So you will be just doing for conservative treatment. Ask for the patient for follow-up, repeat cytology, and HPV testing. There is no need to do cold knife conization in this patient. So second will be wrong. Coming to third, carcinoma in situ. Yes, historically, carcinoma in situ is a classical indication for conization to exclude invasion and treat the lesion. So carcinoma in situ is correct. Then fourth is unsatisfactory colposcopic findings. Entire margin of lesion not. Yes, you are going to do. If the entire transformation zone or lesion cannot be visualized, then you call it as unsatisfactory colposcopy and you will do conization. So first, third, and fourth is correct. So 1, 3, and 4 are correct. Now this is again taken from the Datta's textbook. The indications for the conization is unsatisfactory colposcopic findings, that the entire margin of the lesions are not visualized. So you are going to do conization. Or if you get inconsistent finding, like in colposcopy finding is different, cytology finding is different, and directed biopsy finding is different, so you are going to do conization. If you do endocervical curettage and it is positive, you are going to do conization. And if the biopsy cannot rule out invasive cancer from the carcinoma in situ or microinvasion, you are going to do the conization. There's again one more table for the conization datta. Let's read about it. Colposcopy, if the colposcopy is available, then indication for diagnostic conization is the entire limits of the lesion not seen, transformation zone not seen, evidences of microinvasion biopsy, colposcopy or cytology, significant CIN on endocervical curettage, normal colposcopic findings with abnormal cytology or biopsy, high grade CGIN lesion. Now we have the colposcopy not available. So colposcopy, if your setting does not have colposcopy, then you are going to do conization in the case of abnormal smear with healthy cervix, or the positive diagnosis of CIS to exclude invasive carcinoma, or biopsy report is inconsistent with the cytological findings. Now, coming to next question, which of the following are the factors for the poor outcome following tuboplasty? So you have done the tuboplasty. Now they are asking you which of the following will indicate that the outcome is not going to be good. It is going to be poor. So first is dense pelvic adhesion. So this is correct. Length of reconstructed tube less than 8 cm. No, this is wrong. It should be 4 cm. If the length of reconstructed tube is less than 4 cm, it's going to be poor outcome. Bilateral hydrosalpinx, yes, this is correct. And if you're going to reversal after 5 years of sterilization, so once you have done sterilization operation and then after 5 years you are reversing it by tuboplasty, it's not going to be good outcome. So 1, 3 and 4 are correct. So C is correct. 1, 3 and 4. Again, this is taken from the Datta's textbook. But what are the factors for the poor outcome following tuboplasty? One is dense pelvic adhesions. Second is loss of fimbriae. Third is bilateral hydrosalpinx more than 3 cm. Then length of the reconstructed tube more less than 4 cm. So from here the UPSC has asked the question. Does the length of the reconstructed tube less than 4 cm? Then reversal done after 5 years of sterilization operation. Then presence of other factors for infertility. So in these cases, they are after following tuboplasty.